All right, so moving on, talking about secondary messenger systems. So what happens after we interact with the receptor? What kind of happens downstream from that? We're going to look at a few example secondary messenger systems, some of the more important ones, and we'll see how they can help us to regulate, various, metabolic processes and how we can affect that with drugs. Okay, we're also going to talk about some other, we're going to talk about dose-response relationships. Again, it seems pretty intuitive there. We're going to talk about specific examples and different definitions, including things like ED50, LD50. We're going to get all into that and talk about how that is important for our purposes dealing with drugs. All right, so second messengers. Messenger being the drug coming and binding to that receptor. What are the downstream effects that actually occur after this? The most common ones you're going to run into are going to be things like cyclic AMP, which stands for cyclic adenosine monophosphate, cGMP, which is going to be cyclic guanosine monophosphate, and then we'll see there's calcium. Calcium is a very, very important signaling molecule, as I've kind of alluded to already. Regulating calcium levels are very important, otherwise you can't signal a lot of these things here. We'll also talk about phosphoinositide. It'll come up here. And so these are good and these are important because when they get activated, they can then go on and have downstream effects. Usually things like activating enzymes. Sometimes they can open up ion channels. They can cause all sorts of different effects. And so we'll look at some representative examples here in just a few minutes. Okay, so cyclic AMP is going to be generated from ATP. So you have to start out with a high energy molecule, and then it's going to interact with the enzyme adenylyl cyclase. What do you think that does? A cyclase enzyme. Not take out the phosphate necessarily. It's going to cause it to cyclize, right? It's going to cause it to form a circle, right? Essentially, right? It's going to form a carbon ring, essentially. So again, it's changing the conformation of ATP, turning it into adenylyl cyclase. Again, I'm not going to have you draw it out. It's not really that important to memorize, but when you see cyclase, that's usually what we're doing is forming some sort of ring structure within the molecules there. Now, usually you're going to be targeting protein kinases, and we mentioned kinases do what? Yeah, they phosphorylate something or they add a phosphate to something. So again, usually you're going to find that cyclic AMP is going to target these protein kinases. And I'll show you some diagrams here what that looks like in a minute. Now, this can affect several different, physiologic functions here. So things like, ACTH, we talked about that yesterday. ACTH typically is going to activate cyclic AMP, which can then go on and have some effects on different protein kinases, and usually can affect things like gene transcription. Glucagon, which we know is very important for regulating blood sugar, is another good one here. TSH, or thyroid stimulating hormone, vasopressin, again, all of these we've already talked about yesterday. We already know that their functions are. How they actually work when they get down to the tissue, though, is by activating cyclic AMP, right? So again, looking at the hormone affecting the first messenger, affecting the receptor here. Now we're going to have that second, the G protein actually become activated, and then at this point, once it interacts, this is the adenylyl cyclase here, right? So again, it can still be in the membrane. Sometimes it's going to be located intracellularly, but here we have adenylyl cyclase. Basically, at this point, it's going to change ATP over into cyclic AMP. That is the actual second messenger we're referring to. And then that can go along and activate some of these protein kinases. Once that happens, then you're going to start to go down and it can phosphorylate something. Maybe it goes on and opens up an ion channel. Maybe sometimes it goes on into, changes secretion of something. Again, lots of different things can happen here once you activate these protein kinases. They're kind of non-specific in that regard, but it depends on the tissue you're actually dealing with to see what effects occur here. But the main thing to take away is the G protein is kind of the first part of the first messenger system here. Then adenylyl cyclase causes cyclic AMP to be formed, and that is our second messenger. So one of the things I can use this clinically, I'll tell you, is with dealing with overdoses, right? So I deal with a lot of overdoses. People try to harm themselves quite frequently, or kids get into stuff. One of the things sometimes people will take is called a beta blocker. Have you ever heard of a beta blocker? What might you use that for? Blood pressure is a big one, right? So blood pressure is probably the most common thing, but they can also use it if they have like tachycardia. They can use that to slow down heart rate. One of the big problems we run into, though, is that people will accidentally take their beta blockers, or a kid gets into it, or adult takes too much of it, and it works by blocking the beta receptor on the heart, right? And so we're going to learn later on that beta-1 receptors are very important because when I stimulate those, they cause increased heart rate. So if I block that receptor, what do you think the heart rate's going to do? Going to slow down, right? So all these patients that are coming in, their heart rate's like in the 40s. They are starting to turn blue because they're not perfusing very well. Their blood pressure is low. And so I was like, well, I need some way to reverse this. I need some way to try to get around and try to get their heart rate back up. And so I know the beta receptors are blocked, and that's the main way I would affect that. So I was like, what can I do to get around this? Well, one thing I can actually do is increase cyclic AMP. And I can do that via kind of a backdoor sort of method here. So what I'll actually give is the drug glucagon. Normally we think of glucagon as raising up blood sugar, but it also can help the heart to actually increase cyclic AMP production. So by giving glucagon, which seems kind of doesn't seem like a very rational thing to do, I can give it to these patients, go through this backdoor mechanism to activate cyclic AMP, and all of a sudden their heart rate starts to come up, their blood pressure starts to stabilize, and the patient's doing a lot better all of a sudden, right? So again, you don't have to memorize that example specifically. Just know there are ways that we can kind of monkey with the systems here, that where if one pathway is blocked, I can try to go via a backdoor mechanism and try to get the same sort of effects there, right? So again, lots of ways we can do that. And so when you're giving a drug and it's like, this seems like totally nonsense, like why in the heck would we give this? There's usually some sort of mechanism like this we're trying to target. Okay, and you can see here, if you were to have that Gprotein activate adenylyl cyclase, you have these protein kinases that are going to be activated. This would go down, in this example, into the nucleus and can do things like affect gene transcription. Maybe you have a new protein that starts to be produced, or maybe you would inhibit a protein from being produced in the first place. So here's just another example how this might work. Okay, so I mentioned like glucagon, when that interacts with the liver, what do you think that does? Glucagon in the liver, already mentioned glycogenolysis, and then gluconeogenesis then occurs there. Other cases would be things like vasopressin or antidiuretic hormone in the kidney. We know that helps us to hold on to water. That's going to be another case where adenylyl cyclase and cyclic AMP is being used here. Looking at calcium homeostasis in the parathyroid, right? So again, when we have low calcium, PTH is stimulated or inhibited? Yeah, stimulate, right? So parathyroid is going to try to get more calcium released from the bone in various places, and so this can be affected pretty significantly by that, right? So again, a lot of hormones work through this cyclic AMP sort of pathway here. And then we mentioned, catecholamines, things like epinephrine, norepinephrine. We talk about catecholamines, that's what I'm referring to. Things that kind of increase heart rate, blood pressure. They also work through this pathway. So a lot of different hormones are using cyclic AMP as their secondary messenger of choice. Again, just kind of show you an example of what this might look like. Epinephrine usually is going to be released in kind of response to the sympathetic nervous system being activated, usually fight or flight sort of responses. You'd see the G proteins being activated. That would then activate adenylyl cyclase. You'd have cyclic AMP being formed, and then protein kinases get activated. Now, all this other stuff you don't have to be too concerned with, but if you notice here, we're going to have things like pyruvate being affected here. Glucose is going to be generated. And why would we want to generate glucose? Fight or flight response. We need energy, right? So again, imagine this is the hepatocyte. They're going to be able to break down the glycogen, produce new glucose, and send that out into the bloodstream, right? So again, just one way how we can use cyclic AMP for our purposes here. And again, if I have someone who has low blood sugar, like a diabetic patient, I can actually give them glucagon, and that would actually stimulate the same process to occur, and will release new glucose into the bloodstream. Here's an effect of how you'd see the kidneys being affected here. So for instance, if I were to have vasopressin or antidiuretic hormone come along and start to affect the kidneys here, we'll talk about these structures later on when we get to the renal physiology. But basically what's happening is you can actually have insertion of some sodium potassium pumps. You can also have an insertion of some of these aquaporin channels. Remember, aquaporin is good for transporting what? Water, yeah, actually, it's aqua, it's right in the name. So if I insert more aquaporin channels into the collecting duct here, I can actually absorb more water from the kidneys. So just another example how cyclic AMP and protein kinases can cause that to occur. And then within the heart, imagine this is a sympathetic nerve terminal right here, and this is the myocyte. Here we have a beta adrenergic receptor that is being affected by norepinephrine. So again, if I have a fight or flight response, again, typically your heart rate goes up in those cases, you'd release norepi, activate this, and then that can allow things like more calcium to flow into the cell, and that allows the contraction of the heart to beat harder, right? Harder and faster. Okay. Similar to cyclic AMP, but works in different places, is going to be cyclic GMP. And so this is going to be worked on similar to how cyclic AMP is formed from adenylate cyclase. Cyclic GMP is going to be formed from guanylyl cyclase, right? And so again, this is going to also regulate protein kinase activity. You can either inhibit it or stimulate it. We find this in lots of different places. So places like the intestinal mucosa. Usually here it's going to be regulating ion channel conductance, so how well we're going to have certain ions flowing across the intestinal mucosa. We can have things like the vascular smooth muscle. So this is going to be really, really important for affecting blood pressure, right? Because again, your blood vessels are always surrounded by smooth muscle, and so I can affect how well that's constricting or relaxing. That can affect blood pressure quite significantly. I'll show you a good example of this in a second. But again, this can also cause vasodilation, increased blood flow, and that could be good if you have cases where maybe blood flow is not so great. So what's a case where you may have potentially deadly disease that occurs pretty quick if you have no blood flow going to a certain organ? Well, let's see about how about like a heart attack, right? Again, sometimes I ask questions in a very poor way, so don't feel bad if you don't know an answer. I'm usually asking it poorly. But we'll see the MIs are going to be a big place. The myocardial infarctions are a big place where this is going to be important. So I'll show you how we can affect that. So here's an example of a smooth muscle cell. Imagine this surrounding either, say, the GI tract or maybe in working the blood vessels here. So again, imagine I were to have some sort of nerve affecting, coming in contact with the cell here, and it's going to release NO. What is NO? Besides my daughter's favorite word, this is actually nitric oxide that'll actually be released. And so nitric oxide is going to have a positive effect on getting guanylyl cyclase to be activated, right? So instead of using a Gprotein, this is utilizing things like nitric oxide to actually activate guanylyl cyclase. That is then going to form cyclic GMP from GTP. And then what that can actually do is do things like, allow for some of these ion channels to open up. This may allow for calcium to flow out of the cell. Usually it's going to cause this relaxation to occur for these cells, which is good if I have too much constriction going on. A good example of ways that we can actually affect this would be, because again, you don't want to have cyclic GMP kind of floating around forever, because then I could never have a constriction actually occur with that. So you have to have enzymes that are responsible for actually breaking down that cyclic GMP, so that way you can allow for, various effects to occur. So basically, there's an enzyme here called phosphodiesterase. Again, you have to memorize this example. I like to kind of illustrate this so people kind of know what's going on. Has anyone heard of the drug sildenafil? The little blue pill. Never heard of Viagra? Viagra, yes. So used for what? Erectile dysfunction, absolutely. Sometimes when I'm working at Nemours at the Children's Hospital, we give little girls Viagra. Sounds weird, doesn't it? You can use this for other cases too, and I'll show you why in a second. So basically, if you were to have, say, a smooth muscle cell here, and I want that to stay relaxed, say, for instance, I want to increase blood flow to the penis, or say I want to increase blood flow to other areas, I can basically affect the system by actually inhibiting the breakdown of cyclic GMP. If I have more cGMP around, I can cause more of that calcium to flow out. I can cause more relaxation there, which is good for if you have erectile dysfunction. But the other place we use it for more commonly is in a lot of our cardiac kids. Has anyone heard of pulmonary hypertension? Basis where the vessels in the lungs are too constricted, and that impairs oxygenation. Basically, if you're impairing blood flow getting through the lungs, that impairs how much oxygen you can get into the blood, and that can affect the whole entire body, right? So again, pulmonary hypertension can be very severe. By giving patients something like sildenafil or some of these other erectile dysfunction meds, I can actually prevent that phosphodiesterase from working, and I can keep higher levels of cGMP, and that allows those pulmonary vessels to relax and allow for better blood flow and better oxygenation. Right, so people think it's weird when they're giving like Viagra to like little kids, but it totally makes sense when they have pulmonary hypertension like that, right? We're not using it for any other purpose, just for that specifically. So again, you don't have to memorize that specific detail. Just know that cyclic GMP is usually good for smooth muscle relaxation, typically, right? I'll show you another example here in a second. Okay, so vasodilation, again, very important aspect here. Usually nitric oxide is going to be one of the big things, and this is going to be either nitric oxide working directly on guanylyl cyclase. You can actually find that in some cases may be converted into other products like prostacyclin or PGI2. Again, that can actually activate adenylyl cyclase. So sometimes you actually have similar products, similar second messengers are working in tandem essentially. So by having cGMP and cGMP around, you can actually cause kind of synergistic vasodilation. But the main thing we're focused on right now is cGMP. So imagine you were having a heart attack. What's kind of the first manifestation of that you get? Chest pain, absolutely. So you get chest pain. It's usually indicative of, what do you call chest pain? Angina. Some people say angina. I like just say angina. No one laughs at you when you say angina. And what do you give someone who's having angina? Give them nitroglycerin, right? So again, and if you don't know, that's fine. We're gonna learn about these later on when we get to the actual specific drugs, but this is just a really good example. So I can give you nitroglycerin. You think, why would you give nitroglycerin? Do you want to blow your patient up? No, you don't. However, what it does is it actually donates nitric oxide. So it's able to be converted to nitric oxide. That can then activate guanylyl cyclase. That can then activate production of cGMP, which then allows those protein kinases in the smooth muscles to cause relaxation, which is good because what is the cause of angina? Yeah, my coronary vessels are too constricted. I'm not getting enough blood flow. Usually they're kind of narrow due to things like atherosclerosis, but they're too narrow and they can't allow good oxygen-rich blood to get to the heart, and that's what is causing that chest pain, is that ischemia, that lack of oxygen getting to the heart. So by activating this process, getting more cGMP around, I can vasodilate those vessels, and I can allow more blood flow, and then I can relieve that pain, hopefully, right? Some people are too blocked off that doesn't matter how much nitro you give them, you can't fix that. But typically, we'll give this to patients who have angina, and we'll say, hey, go ahead and take one at the onset of chest pain, usually on exertion. If it doesn't relieve your chest pain, who do you call? 911, right? So you call 911, they can come in, they'll probably give you some more nitro and give you some other stuff to try to fix you. But this is the process of how we're actually causing this to occur here. Make sense? sort of. I'm sure. Another pathway here we use very frequently is calcium, and also this inositol triphosphate. You can just kind of abbreviate to the IP3 pathway. And calcium actually throughout the body gets probably used more than cyclic AMP even does. You can see this being used in cases where neurotransmitters are being utilized. The glutamate uses calcium pretty frequently. Growth factors, some hormones, all utilize calcium. Calcium is also super important because if you didn't have calcium around, you could not contract your skeletal muscle essentially, right? And again, we mentioned calcium usually gets sequestered away in the sarcoplasmic reticulum, but very, very important that we can control that. Secretion of certain substances can be in response to calcium. So, for instance, when I have which cells of the pancreas release insulin? Your beta cells, right? So again, this is actually kicked off by increasing calcium release within those beta cells. That can stimulate the release of insulin from those vesicles that are contained within the beta cells, right? So again, there's lots of different ways we can utilize calcium here. It can also affect cell division. And then we're also going to see the IP3 is the main function there is going to be able to mobilize calcium from storage rather than helping to facilitate these other effects that are occurring there. So I'll show you what that looks like in a minute. So basically, the enzymes we're going to be dealing with is one called phospholipase C. It's basically going to be a membrane-bound enzyme, similar to how like adenylate cyclase was membrane-bound. And then it's going to be activated by Gprotein in this case. And then when it happens, it's going to be activated. You're going to have phospholipase C actually break down into two products, essentially, right? So we're going to have this phosphatidylinositol 4,5-biphosphate. You don't need to know what that's called, right? Basically, you can just call that IP3. And there's also going to be this diacylglycerol, DAG, okay? So basically, just know that phospholipase C is going to break down this product into IP3 and DAG. The IP3 can then go along and it is able to help to do things like, increase release of calcium from the endoplasmic reticulum, where it usually gets stored there. And meanwhile, you can have DAG, it's still associated in the membrane and can activate protein kinase C. And there's a lot of words, but when you look at the picture, it'll make a little bit more sense there. So looking at this, imagine I have a G protein that's being activated by some sort of signaling molecule that's going to then activate the G proteins. And here's our phospholipase C, right? So starting off this phosphatidylinositol, basically this is going to get broken down into that diacylglycerol. That can have some effects on protein kinases, but that IP3, this is the important part, here actually goes along and will open up these channels here to allow that calcium to flow out of the endoplasmic reticulum and then have whatever additional effects it's going to have. Okay, so again, just another signaling pathway. A little different than CGMP, a little different than cyclic AMP, but this one really relies a lot on calcium. Okay, so a good example of this, how this may be affected, and again, every tissue cell typically has multiple receptor pathways. Similar to how I mentioned on the heart, I have beta receptors, and I also have that G proteins that can affect cyclic AMP. There's lots of different ways you can get the same sort of effect out of these cells, and usually they're working in tandem in a lot of cases. Here's a good example of looking at a vascular smooth muscle cell that can be affected by things like angiotensin 2. Anyone ever heard of angiotensin 2? We're going to look at angiotensin converting enzyme inhibitors a lot when we get into the cardiovascular stuff, but this is really an important one for causing vasoconstriction. That's why a lot of people have hypertension due to angiotensin 2. Things like epinephrine can cause this to constrict as well. You can find things like acetylcholine can have effects here. So again, there's lots of different ways that we can get the same effect out of these cells. It just depends on the tissue you're dealing with, and that's why you may have this kind of gives you a reason why we would combine different drugs together. Usually we're going to, when I'm adding on two drugs to do one thing in a patient, it's usually because they have different mechanisms and they work synergistically together. And so it's important to understand kind of what the different influences are, what the different receptors that are available, so that I know which medications I can mix together in order to get the desired effect out of here, right? So for instance, I'm trying to lower someone's blood pressure, I can give something that affects angiotensin 2 and something that blocks, say, epinephrine. By doing that, I get more bang for my buck than giving, say, two drugs that work on angiotensin 2, right? So again, specific examples we'll get into in Farm 1 and Farm 2 later on. Okay, so any questions on receptors? Let's go ahead and do a 10-minute break. We'll come back and then talk about dose-response relationships. Questions from the first half, receptors and second messengers? All right, so next up we're going to talk about dose-response relationships. What do you think a dose-response relationship is? Perfect, thank you so much. Yeah, so dose you give and what kind of response I'm going to get out of that. So theoretically, if I give a bigger dose, I should get what? A bigger response. Absolutely. You guys already know. You guys are halfway to being a pharmacist already. Good job. Anyway. So remember we talked about drug approval process. We talked about the different steps that go into that. Like this is one of the first things they do when they're evaluating a drug is they're looking at what kind of response do they get out of drugs based on the dose you give. So for instance, anyone know like what dose of Tylenol they take? 1,000 milligrams, right? How do they figure out it's 1,000 milligrams? Well, I mean, yeah. So they waited for. Thank you. Correct. How did they figure out 1,000 milligrams is the correct dose to administer? Yeah, they do these studies, right? They say, okay, well, if I give you, say, 500 milligrams, so you get this much pain relief from your headache. If I give you 1 milligram, well, that does nothing. If I give you 10 grams, well, that kills you. That's no good. So, right, so these are kind of the studies they're doing initially to try to figure out. So that way, when you're looking up your stuff in Hippocrates or Micromedics or Lexicon, whatever you use to look up drug dosing, they've already done these relationships for you. They've done these responses to try to figure out, okay, what's the right dose for your patient, right? So when you look to see, like, okay, what's my dose, say, for instance, for lisinopril, right? So it's a hypertension med. They'll know, okay, well, start at 5 milligrams. You can go up to maybe, say, 10 milligrams or 20 milligrams, whatever it happens to be. This is what they're doing essentially to figure this stuff out. So that way, you're not actually doing these studies yourself. Obviously, it's already been figured out for you. But this is kind of what goes into how we determine what a safe and effective dose is going to be for our patient, right? Now, you can do this, say, in a group of subjects. So I could potentially give you all a medication to see, say, I give half of you 10 milligrams of a drug and I give the other half 20 milligrams and compare. That could be one type of study you could do, or you could even do it like as a sort of bench sort of research, where you could do it like on isolated organs, tissues, etc. You can see how different concentrations can affect those tissues. And so basically, we're trying to figure out how much drug is getting to the receptor site, and then how big of a magnitude of response are we getting out of that, right? Just as simple as that. So for instance, it should be the relationship between if I give you 10 milligrams of a drug, I get, say, a 10 millimeter mercury drop in blood pressure, versus if I give you 20 milligrams of a drug, I should expect to see 20 millimeters of mercury potentially. Maybe it's more, maybe it's less. That's how you figure out these relationships here. Now, this data is very important because figuring this out, we can try to look at these relationships. We can do some of the math behind this, and in fact, we'll actually dose drugs based on things like weight, to try to figure out how much drug we should give to a patient. So if you ever see like weight-based dosing, that's a very frequent thing we do, both in peds and sometimes in adults. But it can kind of tell us, okay, well, what's the relationship? How much should I give in order to get the kind of desired response out of my patient? So when researchers are testing a potential drug, they have to show basically three facts. So they should say, if the drug isn't there, you shouldn't get any effect. That kind of makes sense, right? So I shouldn't see any change in blood pressure. Versus if I add more drug, then up to a certain point, I should expect to see some sort of incremental change in blood pressure. So if I give you 10 milligrams, I should get less response than I did if I give you 20 milligrams, right? And then I should be, if I take away the drug, you should go back down to your baseline, right? Once the drug is cleared the system, it should go back down to baseline. Basically, they're showing these three things to show that, hey, the drug we're giving is actually having an effect here. If they didn't show these three things, then they couldn't say that the drug is really effective for what they're testing it for, essentially. So, and typically what you're going to note, and typically you're going to note in these graphs here, that you're going to find response is going to be on the y-axis here, and then on the x-axis, you're going to see the logarithm of the dose. Okay. The reason why we do that will be explained later, but basically allows us to look at very wide ranges of doses. So I can go all the way from, say, micrograms up to grams of a drug, and make it look pretty tight there on the graph. And so essentially what you're going to notice is that if I have no drug around, basically I shouldn't find any response whatsoever, right? That kind of makes sense. However, if I were to start to increase the dose incrementally, I should start to see an increase in effect, right? And then you'll notice here, what's kind of happening right at this point? There's a plateau. Why is there a plateau? That's the max effect I can get out of that drug. Usually it's going to be when you have max receptor occupancy. If I'm filling up every single receptor that's available, I can keep adding more drug, but I'm not expected to see any more effect because all those receptors are already bound up, right? So again, every drug is going to have a curve that looks like this. It can be different relative shapes to one another, but however, this is the same basic kind of S curve you're going to see with all of these drugs here, right? So again, x-axis is usually going to be plotting the concentration of the drug. Y-axis is going to be either the response or the effect. Sometimes you can look at things like enzyme activity in regards to like a percentage. You can look at the levels of secondary messengers that are building up. You can look at membrane potential, secretion of a hormone. Any of these things can be looked at. It just depends on the study you're doing. And again, this is oftentimes what's going on like preclinical testing or during like kind of the first initial phases during drug testing, right? We're not doing these usually in like phase 4 studies. And what is a phase 4 study? You guys remember? Yeah, that's when it's on the market. That's when every one of you, if you take a drug, you're actually part of a phase 4 study. That's already been figured out at that point, right? So one of the first definitions we're going to see here is going to be ED50, or basically the effective dose 50, or the median effective dose. This is basically going to be the dose at which 50% of the population or of the sample that we're looking at is going to manifest a given effect, right? So this is basically going to be the middle of the curve here, and probably is going to be roughly about 50% receptor occupancy, right? So again, if I had a bunch of people, say I had 62 people here in a room, as I happen to have, and I were to give you all a drug, and I can give you ranges of doses, I can figure out what basically the 50% mark is as far as the effective dose is going to be. Now, when I give a drug, say I give you something like Tylenol, do I want to give a dose that's only going to get effect out of 50% of the people I give it to? No, right? So this is not the dose you're actually going to give your patients. Typically, it's much higher than this to try to get up to around 90-ish sort of a percent response. However, this is a good point because I can now compare different drugs together, right? I can start to compare different ED50s to one another to figure out what the differences are between various drugs. Because again, is there only one drug out there for hypertension? No, there's literally dozens of them that are out there, and so it's important we be able to compare those to one another to see which one's more effective, which one's more safe, all those different things to figure out which one is best for our patient. So again, you can plot it either as a linear graph, or usually it's going to be in kind of a semi-logarithmic sort of graph here. So again, this allows us to get the kind of better sort of S-curves here versus looking at something like this and just a kind of linear response. And notice in this case, you're looking at receptor occupancy. That could be another way of kind of illustrating the dose that you're administering for those patients. So typically it's going to be a semi-logarithmic sort of graph here. That helps us to also kind of condense down the doses that we're giving, especially when you're comparing different drugs together. So I mentioned, for example, something like fentanyl, which is an opioid that is used for pain relief, is dosed in micrograms versus something like morphine, another in the same class, is dosed in milligrams. You want to be able to compare those two together, and by using a semi-logarithmic scale kind of helps with that, right? And again, helps us to make it a little bit easier to estimate what the ED50 is going to be between various drugs. Okay, and so we'll kind of look at these comparisons to try to kind of elucidate some facts from those in a second. So basically the four standard parameters you're going to find here are going to be the baseline response, which should be the bottom, should hopefully be 0. Your maximum response, when you have kind of max receptor occupancy, it should be the top response there. And then the slope is going to be kind of determining just how big a change in dose, how big of an effect you're going to see different, right? So you can have curves that have a very steep slope to where very tiny changes in dose can cause big changes in effect, or you may have more of a shallow slope where you can have very wide ranges of doses before you'll see a change in effect that's pretty demonstrable, right? And the ED50 should be the half maximal effective concentration, should be located halfway between the maximum and the baseline, okay? And that's going to help us determine potency. Anyone remember what potency was, Lieutenant? Basically, how much drug am I going to need to give in order to get an effect? So for instance, do I need to give micrograms? Do I need to give milligrams? Do I need to give grams in order to get an effect out of the drug? That is referring to potency. So we'll show you some comparisons here in just a moment. So we can see that the response can be described in a couple of different terms. So you can either have what we call a graded response, like an arithmetic response, where we're looking at kind of the effect at various doses of a drug on an individual. So just one person kind of seeing it, as I increase the dose, what is the change in effect I'm seeing there? Or it can kind of be an all or none sort of response, a quantal response, as we'll say here. And so this is going to be more useful if I'm looking at a population or a sample of people, what the various doses of a drug are going to have, right? So I'll show you some examples of that. So typically when you're looking at a graded dose response here, as you increase the concentration of the drug, you should see an increase in effect. More drug means more blood pressure drop, or more lowering of your blood sugar, whatever it happens to be. And it should be a continuous response, right? So as I continue increasing that dose, you should continue to see that effect up to a point, right? Up to that maximal sort of effect there. And basically you can just describe this as this sort of equation here, where the drug plus receptor should have some sort of complex that forms between those two, and this is going to achieve an equilibrium, right? As I increase the amount of drug I have here, where am I driving that equation? You're driving it more towards having that drug being bound to the receptor, right? So similarly, if I were to say decrease the receptors here, where does that drive the equation? Back over in this response. So if you had fewer receptors, if you had downregulation, you expect to see less effect out of that drug, essentially, right? So you can kind of think about it from those responses there. Anyway, again, max response should occur when you have all the receptors are being occupied. Once you have them all saturated, at that point you can't really get any more effect out of that. So again, it should be continuous, should be a gradual sort of effect you're going to see with that. But this will be in contrast to the quantal response, which is going to be more of an all or none sort of phenomenon, which we're looking at in patients. And so again, we'll show you a graph of the relationship showing that graded dose response. The ones we've been looking at have been graded dose response curves. So So again, for a given drug, again, when you have 50% max occupancy of those receptors, that should be your ED50 right at that point there. Okay, so looking at these, this is very good for helping us to compare multiple drugs together. So I'll show you an effect here in just a second. Basically, drug response curves can be looked at both in terms of their potency and also their efficacy. And again, efficacy is referring to what? How good is the drug at doing what it's supposed to do, right? So again, a higher kind of plateau here, you'd think the drug is more or less effective. More effective, right? Because again, I'm getting a bigger response out of whatever I'm having to look at, right? So again, as I increase the response or increase the max effect, that should be a more efficacious sort of drug. And then the potency here, by comparing the ED50s, you can see just how big of a dose I need to give in order to get that 50% response here. So again, the farther over to the left is, the smaller the dose I need to give to reach that ED50, meaning more potent the drug is. The farther over to the right it is, the less potent the drug is going to be. Okay, make sense? So again, I can say fentanyl is more potent because I'm giving micrograms of it to get an effect versus morphine, I have to give milligrams for it. Does that mean that fentanyl is better drug than morphine? Just means the doses are different. Just means one's more potent than the other. I have to give a lot less. And if you screw it up and I give milligrams of fentanyl to somebody, guess what? You're going to kill them. Versus if I were to give micrograms of fentanyl, guess what? They're not going to have any pain relief. It's not going to do anything for them. We saw a recent news story, because you guys know we're in an opioid epidemic. There's a recent news story where they busted someone who had, I think it was like 115 pounds of fentanyl. And again, a usual dose for somebody is like 50 micrograms, and they had 115 pounds of fentanyl, and they equated it to how many people it could kill based on a 200 microgram dose, and it was like something like millions of people. You do the math yourself, but again, it's something where it's like, man, that's a really potent drug. You don't need a whole lot of it to actually get the effect out of there. Versus morphine, you need something like milligrams of it, right? Anyway. Comparisons, we can kind of look at different drugs together, look at their curves to determine which one's more potent, which one's more effective than another one. Okay. All right, so I like to show these curves here. So imagine here you have drug A, B, and C. You notice here the ED50s are going to be different for each one of these drugs, but what do you notice about the max effect? They're all the same, right? So you could say each of these drugs were equally efficacious because, again, if I give the right dose, I'm going to get the same effect out of all three of these. However, which one's going to be the least potent? C would be the least potent because it's farther off to the right, which means I have to give the biggest dose of drug C to get that effect. Maybe I'm giving a gram of drug C, whereas with, say, drug A, which is going to be more potent, I may only have to give, say, a milligram of it. Okay, and again, when you're looking at your drug dosing, like this is already taken into account for you. So that way, when I look up a drug dosing for fentanyl, they've already taken into account it's much more potent than something like morphine. Okay. So again, lowering the ED50 means a more potent drug, but the further over to the right it is, the less potent it's going to be in those cases there, right? All right, so this is good looking at these four curves here. So we have four different drugs here. Notice here's the ED50s for each of these. You can kind of see how they get demarcated here. So in this case, which is the, say, the least potent drug? Yeah, D is going to be the least potent, right, because it's further off to the right. The ED50 is furthest over to the right. Now, which one would you say is least efficacious? Yeah, so again, when we talk about max effect here, you can see D is actually the least efficacious out of the bunch. So least potent and least efficacious. And again, clinically, efficacy is going to be much, much more important than potency because, again, they've figured out the dose for you. But the question is, how efficacious can it be? How big of an effect can I expect to see out of this drug here? Now, which one would be most effective? A and C. Yeah, so A and C, even though they have different potencies, they probably are roughly equally efficacious, which means I can give either one. Really wouldn't matter for my patient. I just need to adjust the dose to make sure that I'm taking that potency into account, right? The second most effective would be, yeah, B in that case, right? They're 3/4 of the way to being a pharmacist already. Good job. Now, again, looking at efficacy, that's the ability of the drug to have an effect. So, for instance, agonists that activate the receptor should have some kind of positive efficacy here. However, what if I had an antagonist? How much efficacy should I see out of that? It should be zero, right? It should just be a flat line along here, right? So again, if I had an antagonist, we mentioned that drug naloxone or Narcan that reverses opioids, that should have a zero effect. It doesn't matter how much naloxone I give. If my response is analgesia, how much pain relief am I giving my patient, it should be zero, right? Because again, that drug just does not have any kind of agonist effect at those opioid receptors like fentanyl or morphine or hydromorphone, whatever drugs you're dealing with. And so again, a drug with greater efficacy tends to be more therapeutically beneficial, more clinically beneficial for your patients than one that is going to be more potent, okay? So in this case, drug C has a greater efficacy than drug B. This would probably be a better one for my patient, even though I need to give more of it to get that effect there, okay? Okay. Again, efficacy is going to be associated with the vertical axis, so the higher that max effect is going to be, the higher that plateau effect, the more efficacious the drug is going to be. And again, unlike potency, this is relatively important because again, if I can, if I need to drop my patient's blood pressure by 20 points, and I have a drug that at max efficacy I can only drop it by 10, do I want to use that drug? Chances are no, right? I may have to use it with a different drug. I may have to combine drugs. And again, one of the big mantras you're going to take away from my class is fewer drugs are better. Even though it's job security for me, fewer drugs is always going to be better for your patient. If you get away with one drug instead of two, it's going to be good for your patient overall, right? And so again, that Emax is what we're going to be comparing between these different drugs in order to understand their efficacy amongst one another. Okay, so we kind of talked about order of efficacy. A and C should be equal, which is greater than B, and then D is kind of the least efficacious, the least effective out of the bunch, right? Now, for instance, if you're trying to decide which drug you want to give your patient, say like A and C cost like $1,000, but D is say only like $10, and your patient maybe doesn't need all the effect out of this, which could be a good drug for your patient. D might be a better option for them, right? So again, it depends on things like cost. It depends on their insurance, and all kinds of different things can go into deciding which drug is best. Even though there may be one that has like this is absolutely the most efficacious drug on the market, if the patient can't afford it or if they can't take it due to side effects or contraindications, it's no good for them. It doesn't matter how efficacious it is. They might have to choose a different option. Okay. So again, looking at the ED50, a lot of this goes back to the affinity of the drug for the receptor. We mentioned things that have low affinity, which means it doesn't really bind that tightly to the receptor. Some things can have very high affinity and bind very, very tightly to that. And that can kind of show you basically, it can affect how efficacious the drug may be and how potent it may be, depending on several factors. But basically, the drug's action is going to be affected by the quantity of drug that reaches the receptor. So for instance, if I need something to work in the CNS, I need to cross that blood-brain barrier, but the drug is at a point where it's chemically unable to cross, it's not going to have any efficacy. It's not going to do anything for us. So again, that would be a bad drug in those cases there. But it also depends on the affinity there and how well it's going to bind to that receptor. Oftentimes you may find that there are endogenous ligands or endogenous products that our body produces that may be in competition for those same receptors. So you want drugs that come in and be able to kind of displace those, be able to bind to it very effectively, right? We want to have good affinity in those cases. So, and then there's also the concept of intrinsic activity. So again, we mentioned there's full agonists, which when they activate the receptor, it's 100% activation, but there's also what we call partial agonists. What do those do?
Partial.
Yeah, you only not the number of receptors, but when they activate a receptor, you may only get partial effect out of it, right? So you may only get 75 or 50% of efficacy out of that versus a full agonist. And this is goes back to that intrinsic activity. So once it actually binds, how well is it able to get that effect out of there? So for instance, when we're comparing something like a full agonist like morphine versus a partial agonist like buprenorphine or Suboxone, you only maybe get partial effect out of that, which may be okay for depending on the situation. But again, partial agonists have less intrinsic activity than something like a full agonist would. Okay. And then antagonists should have no affinity whatsoever. It really should have, or at least no intrinsic activity. It really should not be able to activate any effect out of that receptor because it's an antagonist in that case. I'm sorry, antagonists only have affinity, they have no intrinsic activity, right? So we want them to bind to the receptor, but we want them to have no effect once they get there. Okay, so then looking at the quantal dose response relationship, again, this is more of an all or none sort of phenomenon when you're looking at more of a population rather than looking at an individual person. Again, you're going to find that similarly, it's going to be the graph is going to have the dose on the x-axis. The y-axis is typically going to be the percentage of subjects that have the desired effect, right? So this could be several things. So for instance, when you're dealing with like anesthesia, typically when I'm trying to anesthetize a person for surgery, I want them to be asleep, right? So this could be what dose of drug do I need to give to get 50% of the people asleep? 50% are still awake, 50% are asleep. That could be the case. Or it could be like how many people achieve a 10% drop in blood pressure or achieve, this much rise in their blood sugar or whatever it happens to be. That's basically what you're looking at. How many people actually achieved the desired effect that I have defined. So again, all or none phenomenon. Sleep's pretty all or none, right? So once you fall asleep, you're asleep. If you're awake, right? Sleep in this case would be defined as an all effect. Awake would be the none effect. Now imagine if you're about to go to surgery, do you want to get the ED50 to where only 50% of people are going to be asleep in that case? The other 50% of people are screaming, awake, they're getting cut open. No, you don't want that, right? So again, this just serves as a useful tool to help us compare drugs together rather than using this as our dose we're actually going to give patients. So ED50 in this case is the mean effective dose, which is going to be the rate or the dose at which 50% of the people have the desired effect. And then now we're going to start to talk about other factors here. We're going to talk about safety margins for these drugs. There's TD50, which is a mean toxic dose. This would be the dose at which 50% of the population manifests a given toxic effect. So for instance, if I'm giving a drug to try to anesthetize someone for surgery, the desired effect is what? Sleep, good. What might be a toxic effect? Yeah, oh, you could do, well, death will be its own kind of thing in a second here. What could be like maybe before death? Maybe like hypotension, maybe respiratory depression. It could be, seizure. It could be anything, right? We can define the toxicity however we like. And basically it's going to be and this is going to be defined by the researchers and say, okay, what's the dose which 50% of the people manifest that toxic effect? Now, I want to give a dose where I get probably everyone to sleep, but do I want to give a dose where I get 50% of people having toxicity? You'd like to avoid toxicity whenever possible. However, every drug has side effects, and you're not going to always avoid that. So these are going to be useful when trying to determine how safe a drug is based on these various curves, as we'll see in a second. The LD50, or the mean lethal dose, is going to be the dose at which you kill 50% of your patients, right? So again, is this something you want to achieve? Not really, unless you really don't like your patients. That could be a case, but again, it's very useful. Now, do they figure this out in those phase 1 trials? No, they figured this out beforehand because, again, you don't want to kill people. It's kind of unethical to kill your test subjects. They're people. Animals, though, we're a little okay with that. So I'm sorry, pet lovers, but usually this is where they kind of figure out those LD50s are going to be in the animals they're kind of testing on beforehand. I know it's very sad for those little tiny rabbits, but they reproduce very quickly, so their family lineage will carry on. Anywho, so we can compare these 3 curves together to give us an idea of just how safe a drug is going to be. So looking at ED50, so imagine you have a drug right here. So again, this is the percent of individuals having a response, right? So again, with this quantal dose response curve, notice here it's always going to be the percent of individuals getting the response you're looking for, right? So again, it always goes from 0 to 100. Now, the ED50 is going to be determining when 50% of the people have the effect we're looking for, right? And so again, when you have kind of max occupancy, when you have everyone has a response you're looking for, that's when you're going to get the max efficacy there. And then looking at the toxic dose 50. Now, how close do you want these curves to be together? You want these to be as far away as you possibly can, because again, when you're looking at this, if you're looking at say for instance, I have I want to give. Probably I want to get 100% efficacy out of this drug. If I'm doing surgery, I want everyone to be asleep before I, try to cut them open. Again, say I'm giving a dose that's like right here. Well, you want to see how much overlap there is with the actual toxic dose. So this is a pretty low percentage of people that will be manifesting toxicity. Would that be acceptable? Depends on what the toxic effect is, but it could be, right? So again, we want there to be a wide margin between these 2 lines here, because that shows us I can give more of a drug to try to get more people with an efficacious dose before I start to manifest toxicity, right? And then the LD50 should be much, much farther away to the point where it's going to be, no overlap whatsoever. Hopefully there's no overlap whatsoever. Otherwise, it's not a very good drug, right? So again, by the time I reach my plateau effect, I should be nowhere near the lethal effect. Now you're going to find there's some drugs where these curves are much, much closer together, which means you have to be much more careful with them because they're going to have a much narrow room for error. Where if you give small differences in drug dose can change how much efficacy you're going to get, but also how much toxicity and potential lethality there. Okay, so this is what we're going to call our therapeutic effect versus our toxic effect, which is going to give us our therapeutic index. So over here, a TI or therapeutic index, this is basically going to be the ratio between the TD50 to the ED50 in these cases, right? Or potentially I could use the LD50 and the ED50. It just depends on what you're kind of trying to compare there. But usually the denominator there is always going to be ED50, and then you can look at LD or TD50 in those cases. But again, because I'm dividing one by the other, what am I looking for? A larger number or a smaller number? Yeah, because again, if these are very far apart, you should have a much larger ratio between those two, and that's good. That means I have a wide therapeutic index, or I have a wide margin for error where I can increase my dose pretty significantly. I'm not expected to see a lot of issues. Versus it's very narrow, that ratio is very narrow and they're very close to one another. That means that small changes here may lead to kind of big effects in terms of toxicity or potentially lethality, right?
So when it comes to chemotherapy drugs, they just don't care?
They care. I mean, you don't want to kill your patient, right? With chemo, you got to be careful though, because again, that's absolutely a very good point there. So when you're dealing with chemo, like that is a very narrow therapeutic index, right? Because ideally, like chemotherapy is doing what to your cells? Killing them off, right? So especially a lot of like the earlier non-specific ones, we would, like methotrexate, we already talked about that. That has a relatively narrow therapeutic index where if I give too much, I can start to kill off more healthy cells. And then that's only going to cause side effects for my patient, right? So we understand that there's a narrow therapeutic index, and we'll do things to try to mitigate that risk for your patients. However, we know that there's going to be side effects, right? So for instance, with cancer, like we know there's alopecia is a risk. We know infection due to immunosuppression is a risk. Those are things we have to live with. and you have to treat through in a lot of cases because the alternative is not treating cancer and then your patient dies, right? So again, this is kind of a double-edged sword in those cases. However, for a lot of other things, or at least with cancer in that regard, if you can use something that's much more specific just for targeting a cancerous cell. So for instance, we were talking about tyrosine kinase receptors. There's some new therapies that are available to where cancer cells, if they have a particular mutation, only expresses one particular receptor. If I can give a drug that just targets that, it doesn't hit all these other healthy cells around it. So that has a much wider therapeutic index because, again, I'm only targeting the bad cells, right? I'm going to be leaving the healthy cells relatively untouched. And so, again, we always are shooting for that sort of drug, but, again, a lot of cases, especially the older ones, they're not really that specific, and there's a lot narrower therapeutic index. Very good point there. So, yes, we do care. However, we got to deal with the good and the bad in those situations there. So everything in medicine is a risk-benefit analysis, right? Even if I decide to give someone Tylenol for a headache, I have to kind of look at the risk versus the benefit. Are they an alcoholic? Do they have existing hepatic issues? Like, do I want to give this to them because I may tip them over the edge there? It's always going to be a cost-benefit analysis, or risk benefit, I should say. So again, looking at a curve like morphine, you would see here's your margin of safety, right? So again, even as I'm starting to increase my dose here, really shouldn't see much toxicity, but again, not a lot of people are getting the effect they're looking for, right? As I continue increasing the dose to a point where I'm getting probably close to everyone getting some efficacy, this is where I'm going to start to see some overlap. And this is where I'm going to start to see some more toxicity being a thing here, right? So for instance, in the case of respiratory depression, right? This is usually the thing that kills people when they overdose on opioids. As long as I'm giving something, in the normal therapeutic dose, I really shouldn't have a lot of overlap there. However, if someone's trying to abuse these drugs, or they're trying to overdose or something, that's when they're going to kind of go way farther right on the curve, and this is where we're going to start to see a lot of that toxicity develop. Okay, and you can find that even within individual patients, they may have things that may shift those curves around on you. So for instance, if they are, say, more at risk for respiratory depression, maybe they have concomitant respiratory disease, that may move that risk over a little bit to the left, make that therapeutic index a little bit more narrow, right? So these are things you have to kind of think about conceptually with your patients and say, well, what is their risk for developing some of these issues here? So, again, therapeutic index is just a simple kind of equation there. Typically, you want a bigger number here because that's going to give us a wider therapeutic index, right? It's going to give us a wider margin for error. A really good example of this are going to be some of the medications we use for depression. And you guys are familiar with black box warnings? Ever heard of that? You know what a black box warning is? The big black box that shows up on the top of the package insert for the drug that says, hey, this is the stuff that you should really be paying attention to because this may kill your patient or cause really severe side effects or something. So if a drug comes up with a risk like that, something like, hey, these drugs might cause your patient to want to commit suicide. That's a black box warning, right? So it's something the FDA, the Food and Drug Administration, decides goes on top of those drugs. And so a lot of the depression meds all have a black box warning that says, hey, this can have increased risk of suicidality. We'll talk about why that is in a couple semesters. But the old school drugs we used to use for depression, they were called tricyclic antidepressants. Anyone heard of TCA? So they still get used occasionally, but they were very good drugs for depression. However, they're very dangerous from a lot of other side effects they end up having. So if I were to look at the curves between, say, like a TCA, and say I was looking at the, let's say for instance, that's probably a bad color. Let's say for instance we're looking at the therapeutic index. You say, okay, well, it looks like my drawings are terrible, so just bear with me. Say you're looking at TCA, you see that the efficacious dose curve looks like that, but then when we're looking at the toxic dose like this, there would be a lot of overlap. So by the time I'm giving a dose that's going to be efficacious for my patient, I'm already getting some overlap with the toxicity, right? And so then when people are trying to overdose on that, because we'll see that there's an increased risk of suicidality early on in therapy, the LD50 was even closer, it was pretty close as well, right? So again, efficacious, not super safe from a lot of toxicity and overdose standpoints. However, nowadays you don't really hear much about TCAs for depression. What you now hear a lot about are what? You hear a lot about SSRIs, right? So SSRIs, you can take 10 times, 100 times a dose and not see nearly the same toxicity you would get out of a TCA. So in that case, you see something like, here's the efficacious curve. Again, I apologize for my poor handwriting. You would see something like the TD50 would be like way over here. So even if they took like a 10-fold overdose of their drug, you really don't see a lot of toxicity associated with that. You may see some, but not as much as you would see with the TCA, right? So again, much safer drug because this margin of error here is much wider than it would be for the older drugs, which is good. A lot of the newer drugs we have nowadays tend to have a lot better safety profile than some of the older ones do. That's great. A lot of the new cancer drugs will have a better safety profile than a lot of the older ones, like methotrexate and other ones. Kind of make sense? Okay, so this is how this stuff comes up, clinically for our patients. You're always making a risk-benefit analysis to determine whether this drug's a good fit for your patient or not. Okay, so I mentioned that ratio there's a therapeutic index. Obviously, a bigger ratio is going to be better for your patients overall. Okay, so again, a high TI is going to be preferable to a low one. So for instance, something like a diazepam. Anyone ever heard of the drug diazepam? Valium is a brand name. It's a drug sometimes used for anxiety, sometimes for seizures. This one has a therapeutic index of like 100. So it's somewhat forgiving. I can give a big dose of it to get a good efficacy out of most of my patients. I shouldn't see a ton of toxicity. However, this other drug we mentioned earlier called digoxin, it's a cardioactive medication. You're going to see for a lot of cardiac active meds, they tend to have a lot more narrow therapeutic index because, as we'll see later on, that anything you can give to treat an arrhythmia, guess what? It could also cause arrhythmias in and of itself, which is always a risk there. And so that one would have a narrow therapeutic index. This one you have to be much more careful with the dose, right? And so we can do things. We can do things like looking at our patient's organ function to make sure they can process it appropriately. We can do things like measure drug levels in some cases to make sure they're dosed appropriately, make sure they're high enough to be efficacious but not too high to be toxic. And we'll look at therapeutic drug monitoring a little bit later, which is what that process is. So we'll have a list of drugs that we'll call narrow therapeutic index drugs. That basically means that ratio is very small between the therapeutic dose and the toxic dose 50, right? So again, we call that narrow therapeutic index. And whenever you hear that, you want to keep your ears pricked up for those drugs because those are things that, while very efficacious in some cases, can also potentially harm your patients, either having pretty bad side effects or potentially being fatal in some cases, right? So in that case, a tricyclic antidepressant is a narrow therapeutic index drug. Digoxin is a narrow therapeutic index drug. Those are the ones you got to be careful with. Okay, so we'll talk about therapeutic drug monitoring. We have a whole section on that later on. That's what we do to make sure we keep those drug levels in check by measuring it in the blood. All right, so just some other examples of narrow therapeutic index drugs. You don't have to memorize this list, but as you learn about these drugs and various disease states later on, you'll get an idea for which ones are going to be a little bit more dangerous to work with. So for instance, a lot of the psych meds, a lot of meds for seizures tend to be narrow therapeutic index, so things like phenobarbital, carbamazepine. These are blood levels we're measuring to make sure they're staying within that right range. So again, if the patient is, say for instance, I have a patient with epilepsy, I'm giving them carbamazepine for that. If the level comes back at 2, what might you think you're at risk for? Taken for seizures. So the level's too low, they could have a seizure, right? So that's not efficacious, right? However, if I get the level too high, they start to get above that, you can see all kinds of issues that pop up. They can develop, some, CNS depression, nystagmus. Anyone know what nystagmus is? Eyes are kind of jittery, right? So they can see ataxia. What is that? Kind of impaired gait because again they're so sleepy and they're the CNS is kind of slowed down to a point where they're kind of stumbling around. They could be a fall risk and hit their head. So again, it's considered a narrow therapeutic index. You want to keep it within that little tiny window, otherwise they're going to run some issues, right? So again, if we can use safer drugs, we always like to. However, sometimes you may have patients that don't respond to the other drugs. Sometimes you may have cases where they cannot tolerate the other ones due to side effects or contraindications. They have to use these drugs in some cases, and that's why we kind of monitor these. Things like transplant medications tend to be narrow therapeutic index. Heart medications in a lot of cases are. So we'll go over these examples in Farm 1 and Farm 2, but this is just an idea of what you can kind of expect to see later on when we're looking at drug levels. Okay. There's one on there that's called lithium. You guys familiar with lithium? Anyone know what you use that for? Yeah, bipolar disorder. Anyone know what soda used to have lithium in it? Just like Coke used to have cocaine in it a long time ago. 7-Up actually was. It was the original lithiated soda, so they give it and you get this kind of boost in your mood. However, you also could be potentially toxic if you're using the wrong kind of patient. But lithium's a pretty bad drug, but still used occasionally. But yeah, it used to be in 7-Up, so you can look up some pictures of that. Anywho, I kind of feel like I was born in the wrong century. Like I feel like I would have really liked to practice pharmacy like 100 years ago. Back when it was like the Wild West, and like I don't know, you're coughing a lot. Let me give you some heroin. Like that sounds good. Maybe 200 years ago, I don't know. That would have been pretty fun. Nowadays, everything's too safe. I'm like, whatever. Just kidding. Right. So anyway, so again, we like drugs with wide therapeutic indexes. This means, again, this would be something with a relatively small therapeutic index. And we've never heard of warfarin before. What is that used for? It's a blood thinner. It's also a rat poison. We still use drugs like warfarin as rat poison, but also we give it to people because it helps to thin their blood a little bit. That's definitely one that's a very narrow therapeutic index. And so again, by the time you get to the desired effect, you're also going to be running into issues of unwanted toxicities. And with a blood thinner, what do you think a big risk is? Bleeding, right? So again, bleeding is the number one risk that could potentially kill your patient. That's no good. On the other hand, you have something like penicillin, which we use for what? Yeah, for infections, right? So again, penicillin, a very safe drug. I can give a huge dose and not really see any kind of major unwanted adverse effects, right? And again, it all depends on the adverse effect you're talking about. You can kind of define that, and then the researchers will do that when they're making these curves up.
Do y'all count allergies and adverse effects?
We'll talk about adverse effects a little bit later. Allergies tends to be more of it's kind of an idiosyncratic sort of response. Like you can't really determine who's going to have an allergy or not. So that's not normally taken into account. Now there are some drugs you can give where you have a higher risk for allergy, and that you can kind of predict in some cases. So for instance, when we're giving proteins, a lot of times if we're injecting proteins into somebody, they have a higher risk of having a reaction. And we can kind of anticipate that sort of thing. But in a lot of cases, allergies are kind of, it's impossible to predict who's going to have a reaction or not. So you don't normally count those in one of those things that we're usually taking into account. However, if somebody like warfarin, I know that's thinning the blood, I know bleeding is a risk, that I can absolutely kind of measure there. Good question though. Okay, so again, looking at our summary of curves here, we need to use both quantile and dose response curves. Our researchers use both of these in order to determine what a good, safe, and effective dose is going to be for your drug, and determine kind of how potent it's going to be, how efficacious it can be. And then by the time it gets out in the market and you see your drug references and they have the listing of the dose and all that, it's already been taken into account for you. But this is kind of what goes into determining how efficacious, how safe a drug is going to be based on these things like therapeutic indexes and et cetera. Okay, so really important information to be able to kind of internalize and then apply to drugs when you're deciding which one's going to be good for your patient or not, right? Because that's what it ultimately comes down to is like, do I describe this drug to this patient, and what dose should I prescribe? How often should I give it, et cetera, right? Okay, so individuals can vary quite considerably in their response to a drug. You may find that patients, you maybe have two patients that are similarly sized. I can give them the same dose of drug. One person has major side effects from it. The other person has no problems whatsoever, right? You can find the same person over time may have different response to a drug based on things like organ function that can occur here. And so you need to be able to kind of predict what those factors are that may predispose your patient either having no efficacy, limited efficacy, or maybe some toxicity that can develop there. So we'll talk about these various responses here. So we'll talk about idiosyncratic responses. We'll also talk about things like tolerance and tachyphylaxis. This is your 25-cent word of the day. You can use to impress your friends. And then we'll talk about hyper and hyporeactive responses. Okay. So idiosyncratic responses, thank you for that segue, talking about allergies. These tend to be rare sort of abnormal responses to drugs, right? So again, they cannot be explained by the pharmacologic action of the drug. So when you learn about penicillins, which is something, something you'll see on a lot of patients' charts, they'll list their allergy, they'll always say penicillin. You say, what kind of reaction did you have to penicillin? And they'll say, I don't know, my mom told me I was allergic. And you're like, great, now I can't give you like 90 drugs because of this allergy. Allergies are always going to be a big bugbear for a lot of practitioners and trying to determine like what's legitimate, what's not. But basically, it's not explained by the action of the drug. So for instance, penicillin works to break down bacterial cell walls. That's its mechanism. That's what it does. It does not cause allergic reactions based on its mechanism. So you can't really explain it because we can't really predict who's going to have those reactions, right? An allergy can kind of be lumped in with this, but it's not a true allergy at this point. We'll talk about allergies a little bit later. And these can also not be reproduced with reliability, right? So again, I can't give that same dose of a drug that a person had kind of an abnormal reaction to, give it to a different patient, and expect the same thing. Again, it's idiosyncratic. You cannot predict when it's going to occur there. So some of this case, it may be or may not be dose dependent. So sometimes you may see if I increase the dose, I'm more likely to see it. That may be the case, may not be. Usually you're going to find that it tends to be more of a genetic predisposition. Someone has a mutation or some sort of genetic predisposition based on heredity or based on several features that make them more or less likely to have one of these occur here. So a good example of this would be something like Primaquine. It's a very old school malaria drug. And so you'd find in some patients they develop this idiosyncratic response. It would be hemolysis, which what is that? Red blood cells are just breaking open, right? They're just lysing open, and they'd have a severe hemolytic anemia, where basically all that hemoglobin is being spilled out from the red blood cells. They're not able to carry oxygen appropriately. It's no good. You don't want that to happen, and that would be caused by someone who had a glucose 6-phosphate dehydrogenase deficiency. So if you ever hear G6PD deficiency, that's something again you want to prick up your ears for, because a lot of patients don't know they have it. However, when it's been discovered, you have to be very careful about what drugs you use for them, because some of the drugs maybe it'll tip this off. More so than others, and so you can't really predict who has this deficiency because we don't test for it normally, and because it is pretty rare. But you may give your patient that may be at risk for malaria, give them Primaquine. All of a sudden they come back and they're pale and they're diaphoretic. What's going on? You measure their CBC, come back and they're anemic. You're like, what the heck's going on here? It could be related back to the G6PD deficiency, right? That would be an example of idiosyncratic response. In some cases, you may have hypo or hyperreactive responses, basically the patient either not responding very well or maybe they're having kind of the opposite sort of effect what you would expect to see. A good example of this would be Benadryl. Sure, most people have probably taken Benadryl at some point in their life. What is a common effect of Benadryl? you get tired, you get kind of sleepy, right? So some people use that for a therapeutic effect. Other people see that as an adverse effect, depending on the situation, right? If you took a dose of Benadryl right before you came into class here, that would probably be a negative effect, right? You probably don't want to be falling asleep. I can do that on my own. You don't need Benadryl for that. However, if you're trying to go to sleep at night and you're really kind of ramped up, a dose of Benadryl may be what you need to go to sleep. So again, depending on the situation, some side effects could be positive effects. However, you may find that some patients may not actually get very sleepy from that. This is something you see with kids with some regularity. It's called a paradoxical reaction, where basically you can give a dose of Benadryl to a little kid, and instead of them getting sleepy, they get more hyper than you've ever seen. They can start bouncing off the walls, they're going crazy, they're running through the ER, just tearing everything down. Very, very disruptive to your ER flow in a lot of cases. That would be an example of a hyporeactive sort of reaction there, right? So again, they're having the opposite effect of what you would expect to see. Yes, ma'am. That typically wears off. Some of it has to do with the dose you're administering based on the child's weight, but some people still have it when they're even an adult. Some people take it and they'll just get totally squirrely when they're on it. And, yeah, so you would be an example of that. So maybe you could take a dose of Benadryl before class, and then you could come up and kind of demonstrate your effects there. I'm just kidding. You don't have to do that. Try not to make students get into guinea pigs as best I can. But anyway, yeah, so sometimes people will maintain that the rest of their life in some case. We see it more often in kids, though. It's kind of where you primarily see it. Some people may get really, really sleepy when they take Benadryl, much more so than you would expect to see at a typical dose. All just depends on the patient. In some cases, opioid pain medications. So you may see something like excessive sleepiness. Take a normal dose of, say, something like codeine. Codeine is kind of a wimpy sort of opioid, but it's kind of an old drug we use quite frequently, cause excessive sleepiness or respiratory depression. Now, in some cases, this could also be a genetic sort of thing, and so this is kind of a big deal change we had within the past couple of years as far as pediatric management of pain. So there was I mentioned, anyone ever heard of Tylenol number 3? Tylenol mixed with the drug codeine. And codeine itself, not a great opioid. It doesn't really do a whole lot of, cause a whole lot of analgesia. However, your liver can metabolize it into morphine. Morphine is a very good analgesic. So you would find some patients could metabolize this into morphine very easily. They had an overabundance of CYP2D6. This is an enzyme we'll talk about later on. They could produce a ton of morphine that was very good for pain relief. Some patients had very low amounts of CYP2D6. They could not metabolize it very well. They didn't get any pain relief from it, right? They would just take it and they're like, I don't feel any change. So what we're having is we are having some kids, and again, this is not a problem we had specifically at Nemours, but this is more kind of nationally a problem in pediatrics, is you'd have these kids who are coming in for obstructive sleep apnea. Usually they would have kind of these big giant tonsils they need taken out, right? So they would go into surgery, they have a tonsillectomy, they would come back out. And then what do you kind of note about tissue after surgery? Is it usually kind of nice and normal? Is it kind of inflamed and gets swollen? Usually gets more swollen, right? So these kids already have obstructive sleep apnea. Now they have the swollen tissue, and now some of these kids were very rapid metabolizers of that codeine into morphine. And one of the big side effects you worry about with opioids is respiratory depression. So kids are already obstructed. You add on this respiratory depression effect, and again, it's hard to predict who would have that reaction. And some kids died because of that, right? You just lay them down and go to sleep and never wake up. So because of that, because we could not, you can't reliably predict who's going to have that effect or not, we just said, we're just not going to use codeine anymore. If they need pain relief, we'll give them something else. And so that was a big a big shift in practice where we pretty much took codeine off of our formulary. We just don't use it at Nemours anymore because we cannot predict who's going to have that problem, and we just got rid of it, right? So again, this can change basically how you use drugs or which drugs you use in a lot of cases. Now, tolerance is anyone know what tolerance means when I say that? So it's like maybe being tolerant of your neighbor who's maybe like bringing like smelly snacks or something to class, or
decreased effect over time, the same dose.
Perfect. Yeah. So if I take the same dose of drug every single day, I'm going to see a decrease in effect over time. My body, in order to maintain homeostasis by doing things like down-regulating or up-regulating receptors, you kind of get used to that drug over time, right? So for instance, if I take a dose of Benadryl today, I may get really sleepy, but if I took that same dose of Benadryl every single day, I probably get tolerant to those effects over time. Now, how can I overcome that? Increase the dose, right? So again, you can find that, especially with like opioids, this is a common thing where people who have chronic pain, they typically need to go up on their dose of opioids over time in order to overcome that tolerance. And so that's why we saw some issues where if you were to have like little kids, or not little kids, probably teenagers, right? You ever heard of like, you may have been around, hopefully not attending, but ever heard of like a pill party? People go and they grab pills that are like grandma's cabinet and they take it to a party and everyone just kind of take whatever. Well, your 90-pound little old lady grandma could be on some really rocking doses of oxycodone and hydrocodone because she's been on it for years, right? She had a terrible back pain. She's been steadily ramping up her dose over time to where she may be taking a dose that could kill an elephant, right? But people don't realize that, and so we had teenagers that were taking those drugs, and then they would just basically have respiratory depression and die. So again, tolerance takes time, but basically you need to increase that dose in order to overcome that effect. That's the big thing to note with that. This can happen with lots of different drugs. Stimulants, who's abusing caffeine right now? Maybe utilizing caffeine. Every hand should be raised, I imagine, but that's okay if you don't own up. My blood is so laden with caffeine that I really don't get much effect from it whatsoever. I'm just really maintaining normalcy at this point. We'll talk about withdrawal later, but that's another phenomenon too, is like when patients get really tolerant to these drugs. But that's the thing where you can notice, like, hey, if I'm pounding a Red Bull every single class period, guess what? That's going to have limited effect for you, a few weeks down the road.
So on this, can tolerance be considered like if you take a stimulant every day, like an ADD medication, and then you take caffeine on top of that? Could you already kind of be tolerant to the caffeine, so it doesn't have as much of a...
You probably wouldn't. That's complicated. You probably wouldn't be necessarily as tolerant to the caffeine because it's kind of working through a different mechanism than something like, because usually the ADHD drugs are usually amphetamines, so they're kind of working through one pathway versus like the caffeine working through a different one. There's probably some synergism you could probably get from that. You get really kind of ramped up and wired from that. However, I don't know you'd be as tolerant to the caffeine, but maybe on a person-to-person basis, hard to say. Some of you may be experiencing that right now. I have no idea, but we can do some studies. We can maybe figure that out. We can do some dose response studies with caffeine and the effects of Adderall, all that good stuff. Yes, you have to increase the dose in order to overcome the effect. On the flip side of that, we have something called tachyphylaxis, which is basically where even if I increase the dose of drug, I actually don't see any kind of increase in effect, right? So this can happen after the first dose for some drugs. In some cases, you may find it happens over a long period of time. So again, it doesn't matter how much I increase the drug dose, I get no additional effect out of that, right? And so sometimes this is related to like depletion of things like neurotransmitters, related to some cofactors needed for some of these reactions. This is something you see commonly with amphetamines. So again, if I have someone who's really like on a big amphetamine bender, they're taking a ton of amphetamines, you can find they actually deplete a lot of their neurotransmitters to where they have like a major kind of washout period where they just depleted all that norepinephrine, all that dopamine out of their system. And it takes time to replenish that. Even if they took a ton more amphetamines, they don't really see a bunch of effect out of it. A really good example, though, is going to be nitroglycerin for chest pain. We already mentioned that being utilized for angina, using like sublingual nitroglycerin in that case. However, some patients are going to be on nitroglycerin for more kind of long-term control of angina. And so anyone ever heard of like nitro paste or like a patch that you can put on the skin for nitroglycerin? One of the things, we'll learn about that when we get to cardio later on, but one of the things you have to note with that is you have to put it on for 12 hours, and then you have to take it off for 12 hours. It's 12 on, 12 off. The reason for that is that as long as the drug is there, it's going to be depleting some of those cofactors needed to cause that vasodilation, right? To cause that nitric oxide pathway with cyclic GMP and all that to work. So if I deplete all those cofactors, even if I were to have angina develop and I were to take sublingual nitroglycerin, like my, whoever prescribed it told you, they would get no additional relief. They get no additional coronary vasodilation. They still had that angina there. So by having a 12 on, 12 off sort of period, you give the body time to replenish itself, and then when you put it on for the next 12-hour period, it works again. Okay, it's called tachyphylaxis. It doesn't matter how much more nitroglycerin I give. Once that's kind of warding the body out, it's done at that point until you give it time to reset itself. Does that make sense? So you kind of know the difference between like tolerance versus that tachyphylaxis because they are quite different to one another. Okay, so let's see. Got 3 minutes. I think I'm gonna go ahead and cut it there. You guys have any questions I can answer before we go? As we're experts in dose-response relationships, experiment with them. I'm gonna take 10 milligrams of ibuprofen, then I'm gonna try to take 100, then don't do it to yourself. Anyway, all right. Well, if nothing else, then I guess I'll see you guys tomorrow for another round of physio.